We have a 45-year-old female.
Severe abdominal pain. Please help her. She's in so much pain.
Get her into Trauma Bay 1 immediately.
Imagine you are on the shift in the ER and a 45-year-old woman rushes through the ER doors. She is screaming. She is wriggling in pain on the stretcher. She tells you the pain started around 2 hours ago, right around her belly button. But now, it feels like her entire abdomen is on fire. Before the pain peaked, she had a violent, sudden episode of bowel emptying. She looks critically ill, so you step up to examine her. You press down on her abdomen, expecting her to jump off the table. But nothing. Her abdomen is soft, no guarding, no rigidity. So this is the ultimate clinical contradiction. Pain severely out of proportion to the physical exam findings. You run the standard labs, so you rule out appendicitis, cholecystitis, a perforated ulcer, abdominal aortic aneurysm rupture, inferior wall MI, acute pancreatitis, or acute bowel obstruction. Everything is coming back negative. You stabilize her with IV fluids and analgesics, but the clock is ticking and her bowel is quietly dying. On digging deeper into this patient's past history, they found the missing piece of the puzzle. A few years ago, she was diagnosed with atrial fibrillation.
Since your heart rhythm is irregular, we must start you on an anticoagulant.
I understand, doctor, to prevent clots.
Yes, taking it every day is not optional.
But she hasn't been taking it. She was completely non-compliant. Stop right here. 45-year-old female, severe pain out of proportion to the examination, violent bowel emptying, history of atrial fibrillation, non-compliant to anticoagulants. What is your diagnosis? Pause the video, drop your answer in the comments. If you said acute mesenteric ischemia, specifically an arterial embolism, you nailed it. Your clinical instincts are spot on.
With atrial fibrillation, blood pools. A clot forms in the left atrium. It breaks off, traveling down the aorta, blocking the superior mesenteric artery.
Because her heart was fibrillating, blood pooled in her left atrium and a thrombus is formed. Without her anticoagulants, the clot has dislodged, shut down the aorta and jammed itself right into the superior mesenteric artery. The violent bowel emptying she experienced earlier, that was the gut's ischemic response. A massive spasm as the blood supply was suddenly choked off. In this situation, avoid vasopressors. While she remained on a regimen of broad-spectrum antibiotics, doctors ordered a CT angiography to check for a suspected blood clot. This is a massive emergency with a mortality rate between 60 to 80%. You cannot wait for late-stage markers like lactate to rise. In acute mesenteric ischemia, lactate rise is a vital but non-specific indicator of tissue hypoperfusion and bowel necrosis. Gold standing imaging here is a biphasic CT angiography. You are looking for a cutoff in the vessel and a dangerous late signs like pneumatosis intestinalis, it's gas dissecting through the bowel wall. Management is aggressive, fluid resuscitation, correct the electrolyte imbalance, and get broad-spectrum antibiotics on the board immediately to prevent the sepsis. But the definitive fix is absolutely surgical management. An urgent laparotomy was done for an embolectomy and to resect any necrotic or dead bowel. And because the tissue viability is so hard to judge in this moment, these patients almost always require a second look surgery after 1 to 2 days. Acute mesenteric ischemia is stealthy, it's fast, and it is lethal. Keep your index of suspicion high and always trust the pain, not just the physical examination. If this case breakdown helped you connect the dots, hit that subscribe button and share it with your batchmates. And I'll see you in the next clinical case. Stay sharp.